Dr. Vandana, can you please confirm if I'm audible clearly? Thank you, ma'am. Good evening, you all. So in today's session of Pediatric Hematology Oncology chapter of Indian Academy of Pediatrics online teaching program, we will discuss on pediatric classical Hodgkin lymphoma. So as we know, it is a easy to treat malignancy and it's very gratifying as well because the outcome is typically excellent. However, there is considerable amount of heterogeneity exist in the way it has been re-stratified, and the management protocols also vary across the centers. So to understand on that and update ourselves on this topic, we have now three excellent speakers. And as we told the last time, on a lighter note, it's a Bombay Talkie show. So all the speakers are from Bombay. So first speaker is Dr. Badira Parambil. Madam is Associate Professor of Pediatric Oncology, Division of Pediatric Oncology at Tata Memorial Hospital, Mumbai. May I now request to start sharing her screen.
Thanks, Preetham. I hope you can hear me.
Clearly,
Yes.
clearly.
Yeah. Okay, I'll share the screen. Stop. Yeah, as Preetham rightly pointed out, Hodgkin lymphoma is one of those diseases, cancers, where you get an excellent survival rate. So your overall survival is quite good, but there can be a lot of events taking place in the later decade also. And with respect to Hodgkin's, because of the side effects of treatment, more so than relapse of the disease per se. So several collaborative trials have evolved over decades, and the treatment approaches in Hodgkin's lymphoma has evolved from a uniform strategy to risk adapted, then gender based, then a response based, with subsequent consecutive trials aiming at reducing chemo as well as reducing or eliminating radiotherapy because of the late effects. So I will just run you through the stage and risk. So this is a very short presentation where I'll give you an introduction to the staging and risk, and we will do with a couple of quite a few of case scenarios, which will help you to understand how to stage and risk Hodgkin's lymphoma. Now, with respect to Hodgkin's, we have to understand that if you're following a particular protocol, even though the staging is relatively same, uniform, there is the treatment depends upon the risk stratification, which is a bit slightly different. You can find from protocol to protocol. And if you're following a particular protocol, it's best to stick to the staging risk stratification of that protocol and the treatment adaptation of that particular protocol. So, as you know, the clinical presentation, it's mostly presents as a painless lymphadenopathy, mostly supradiaphragmatic in many cases. And mediastinal involvement is also quite known in Hodgkin's, where a bulky mediastinum has shown to be a poor prognostic factor. And these are usually painless, and they usually present as unilateral or bilateral lymph nodes. They may be matted and rubbery. This is a classical description which we all have come across, especially during a pediatrics training and MCQ. Yes, rubbery, matted nose, painless. And Hodgkin's is known for its contiguous spread, that it spreads from the one lymph node region to the other in a contiguous manner. And there are associated B symptoms, which all of you are aware of. But what you have to know about B symptoms is they are mainly three: fever, weight loss, and ranging night sweat. So when you elicit history with respect to the fever, this fever should be an unexplained fever due to some other fever with no other alternative infectious cause for the same. So this is an unexplained fever without otherwise an etiology, which should be there, 38-degree oral temperature for 3 consecutive days or more. So suppose if you have a patient who has had a lymph node which was painless, no fever till 3-4 months now, the lymph node somehow has got infected and he's discharging pus and having fever for last 3 days, that will not be taken as a B symptom. So you have to be careful in classifying your B symptoms or defining your B symptoms, because this is important in your risk stratification and the treatment strategy that you are going to use. So it is a fever due to no other explained cause for the same. Mainly what I mean is an infectious cause. Weight loss, it should be quantified like should be a documented weight loss of more than or equal to 10% in the preceding 6 months. So many times we know that we encounter patients who say, oh my God, the patient has lost weight. So I mean, it has to be a documented weight loss. Again, as I've said, these symptoms have very significant connotation when it comes to treatment. The sweats, night sweats, again, drenching night sweats. Like the sweats should be such that the patient gets soaked with the sweat and is the bed sheet becomes wet. So they should be drenching night sweats. So the definition is very precise and you have to be careful while defining and establishing your B symptoms. So this is a classical Hodgkin's from left. If you go in a clockwise manner, you can see the different histological types. The nodular sclerosis, the uppermost, with mainly the nodular pattern, which is seen on the morphology. This is important with respect to prognosis because nodular sclerosis is less common in the Indian population, more so in the Western population, and it is not as responsive to the Hodgkin's that we see in a population, which is mainly the mixed cellularity, which will have the classic HRS cells in a inflammatory background. So the inflammatory background is quite prominent in mixed cellularity. Also, mixed cellularity has around 90-95% EBV positivity when compared to nodular sclerosis, which has only about 20 to 30, max 40% EBV positivity. This also may partly explain why Indian Hodgkin's, the mixed cellularity with an EBV preponderance may be more responsive to chemotherapy and so. Now, the right bottom corner, you have the lymphocyte rich, which is very rarely seen, and the left bottom is the lymphocyte depleted, depending upon the presence or absence of lymphocytes in the background. One thing you have to know about Hodgkin's is, Hodgkin's is a disease where the malignant cells or the characteristic HRS cells, they are present only in 5% of the total tumor. So the bulk of the mass is mainly inflammatory infiltrate. Now, the importance or the significance of this comes in your workup again. And also when you do response assessment. Now, workup is like any other malignancy. You have to do your basic bloods, complete blood count. Usually it is normal, but you can get neutrophilia, neutrophilic leukocytosis. You can get eosinophilia. You can, there will be lymphopenia. So blood workup may show that. And also very rarely you can have cytopenias in Hodgkin's. So they are not commonly encountered. Cytopenia is usually seen with Hodgkin's in the context of if there is an associated HLH, if there is associated autoimmune phenomenon. Hodgkin's is known to be associated with autoimmune hemolytic anemia. So bone marrow involvement usually doesn't present that much with cytopenias unless there is an associated HLH. So you have to be careful while interpreting your CBCs in a case of Hodgkin's. Then we will do ESR, all the acute phase reactant, CRP, ESR could be elevated. LDH again will show you the burden. Tissue diagnosis, how do you diagnose Hodgkin's? FNAC is should not be attempted in a case of Hodgkin's because it will not give you any idea about the disease. As I've said, in a diagnosis of Hodgkin's, the morphology of the architecture of the lymph node is important. You need to have stromal cells too. So excision biopsy wherever feasible, if not a true cut core needle lymph node biopsy should be the investigation of choice for a definitive diagnosis. So you choose an area which is easily accessible and not difficult to access. I mean, easily doable. So if you have a mediastinal mass, you look for peripheral lymph nodes. If they are present, take the biopsy from there rather than attempting a mediastinal mass biopsy. Now, one of the most important staging investigations in Hodgkin's in the current era is FDG PET-CT. So staging initially, usually in the earlier, all the studies, mainly the staging was a combination of clinical, then you had X-ray, you had then the CT and MRI, which came subsequently. But in the current recent trials in the current era, the FDG PET-CT is used for staging. Now, FDG PET will give you an assessment of the functional aspect of the malignancy, and the anatomical delineation is by CT scan. So you need a combination of FDG PET and CT for staging workup. Because whenever you have, because FDG PET avidity just means that there is anaerobic glycolysis. It can be due to infection, they can be due to inflammation, it can also be due to malignancy. So just having a functional FDG positivity is not enough. You need to have a corresponding anatomical lesion. So this is how the combination of FDG PET CT would help in diagnosis. So a part of the body where you have lymphomatous involvement, there should be an anatomical lesion corresponding to the avidity. Now, as I've said, it is used at the baseline for staging workup. FDG PET CT is also used in the interim assessment as part of early response assessment to delineate how the response is and subsequently decide on RT, and also in the late response assessment and subsequently in relapse staging again. So how do you do PET CT? How do you assess the PET CT? So PET CT is, if you have to say, it's a bit subjective and objective if you look at it if you're using dual scores. So dual scores, it's based on the visual assessment. So dual scores, how do you do this? So if you can see, you have two pools which are taken as reference. One is the mediastinal blood pool and the other is the liver. So these are the two references while you are giving scores in a case of PET CT. Now, a score of 1 means there is no uptake when compared to these. So there is no lesion mostly. So suppose you have a lesion, how you see here in the neck here, there is a lesion. And this lesion, if you compare to it, the uptake is less than or equal to the median. It's less than the mediastinum. So the score will be 2. Now, in this case, for this lesion, you can see the uptake is more than the mediastinum. It's relatively like equal or a slightly bit than the liver. So that is score 3. Now, if you look at this 4, this is more, definitely more than mediastinum, and with respect to the liver also, it is more. This is dual score 4, and when you have intense uptake very much greater than the liver pool, then that is dual score 5. Now, the dual scores with respect to baseline staging, anything from up to 3. So you, when you do a baseline staging, your reference is mainly the mediastinal pool. When you do an interim evaluation or an early response assessment, your reference pool is mainly the liver. So that is how. So for an interim assessment, a dual score 4 and 5 will be taken as positive, but even a 3 will be taken as FDG positivity in a baseline. So baseline mediastinum is the reference pool. Even a 3 will be positive. And for an interim assessment, it is the liver pool, and hence 4 and 5 is taken as positive. So this is the basis of FDG PET assessment. Now, this FDG PET CT is currently used for staging with respect to finding out which lesions are involved. And usually what happens is, as I've said, you should have an anatomical lesion. So you delineate which regions are involved initially. When you do an interim assessment, you look into only these lesions, or if there are any other new lesions. Only presence of FDG avidity elsewhere will not be accounted for in the interim assessment. Now, with respect to whether you need a bone marrow additionally to look for bone marrow involvement in Hodgkin's, became clear with this meta-analysis of around 9 studies, which showed that because earlier bone marrow was needed whenever you had stage 3, 4, or any 2B. Above 2B, bone marrow was needed to see if there was bone marrow studies were needed to see if there was bone marrow involvement. In this meta-analysis, FDG PET CT had a high negative predictive value. The sensitivity was around 97 and specificity was around 99.7%. Hence, it clearly showed that FDG PET CT can replace some bone marrow aspiration or biopsy for assessing involvement of the bone marrow. But one thing to note that is FDG PET CT, the FDG uptake in such a case where there is bone marrow involvement is usually patchy. So there is patchy uptake is more specific for bone marrow involvement. Now we have the staging. So you do your initial, you do staging PET CT. Wherever PET CT is not available, you can do a combination of X-ray, CT, MRI. So that is the adapted staging technique. Otherwise, standard is wherever available is FDG PET CT. So Ann Arbor staging is used for now staging the patients. So once you do the imaging, you stage the patient depending upon the involvement. Now, stage 1, as you can see here, so the diaphragm is taken, is the main point, anatomical region. So anything, if you have one site, involvement of a single site, whether it be above the diaphragm or below the diaphragm, and the single site can be a lymphatic site or an extra lymphatic site. So if it's a single site, it is stage 1. If you have 2 or more sites on the same side of the diaphragm, it is stage 2. This 2 or more can be one lymph node and one extranodal, or it can be both the lymph node, or it can be both extra lymphatic, but it should be on the same side of the diaphragm. Then it's stage 2. Now, if you have a lesion involvement above and below the diaphragm, irrespective of the number, it will be stage 3. Now, stage 4 is disseminated involvement of a viscera. So if you have a disseminated involvement of the lung, then any involvement of the bone marrow, which is usually by PET, it will be patchy uptake. Any involvement of the liver. So any bone marrow or liver involvement is stage 4. Otherwise, any other organ has to have a disseminated involvement, like disseminated bone, disseminated lung, all will be stage 4. So in this context, as I've said, you do a staging. So first you have a patient, you do the imaging, you do the staging. You assess and see whether whatever is the stage 1, 2, 3, 4. Now, I'll also give you an insight to how to assess involvement. So you have the lymph node. So the different studies or different protocols have different ways of assessing involvement with respect to FDG PET-CT. Now, if you look at the Euronet protocols, it says irrespective of FDG ability, a lymph node size more than 2 centimeter is involved. Between 1 to 2 centimeter size, if the FDG is positive, it will be involved. Less than 1 centimeter, irrespective of FDG positivity, it is uninvolved. So this is how these protocols take up. Now, in our institution, in our protocol, a trial which we are running, we are taking with respect to we are seeing the morphology of the lesion, the lymph node, and then the uptake. For us, the size is not a criteria. And for us, any FDG uptake, which is greater than the background activity, is taken as positive, irrespective of the size. Now, how do you do assessment of the Valdez ring? So Valdez ring is purely clinical. So it has to be the clinical assessment. So FDG positivity will be there in physiologically. So based on mere FDG positivity, we don't take involvement. There has to be a clinical involvement. You can assess it by with the help of an ENT physician also. And Valdez ring, usually we do not do biopsy also unless it is a single site. Like you have a single tonsillar enlargement as the only site of disease, which is very rare in Hodgkin's. But that's the only case where you would do biopsy. Otherwise, you would not do biopsy when the Valdez is, to look whether the Valdez is involved or not. Now, how do you assess the extranodal involvement? Now, you also have to know what is meant by an E site. So suppose you have a lesion in a viscera, but it is either contiguous with a draining lymph node, because there is a draining lymph node which is involved and it is contiguous with that, it is infiltrating the viscera, then it is called an E lesion. Also, that's what's called an E lesion. So usually in the context of a lung. So lung, there might be a lesion in a single lobe, but there can be ipsilateral hilar lymph node also. So in that case, that single lung lesion, which is confined to a lobe, will be an E lesion. Or you have a lymphoma, which is infiltrating the chest wall and causing pleural involvement, or you have a pleural effusion, which is not defined or accounted to by venous congestion. That is pleura as an E site. Again, pericardium as an E site would be pericardial effusion, which is not due to venous congestion or some thickening of the pericardium is there. So this is an E site with respect to pleura pericardium. Again, for bone, there is a single site involvement, but there is a draining lymph node which is involved. Then that bone involvement is an E site. If the bone is involved, but there is no contiguous or draining lymph node involved, then that will not be an E site, but that will be a bone met. Now, how do you assess the organ involvement? As I've said, for liver and bone marrow, any patchy uptake will be taken as involved. Mere enlargement of the liver, that is, if you have simple hepatomegaly with no patchy uptake or increased uptake in the liver, will not be taken as involved. Again, as I've said, lung, disseminated involvement of the lung will be taken as stage 4. If you have homolateral lymphadenopathy with isolated lesion in one lobe, it will be taken as an E site. Spleen, again, mere splenomegaly is not an involvement. You should have patchy increased uptake on an FDG PET, or even if the PET-CT is negative, but a UST is showing focal lesions in the spleen, that also is taken as splenic involvement. CNS involvement is very rare in Hodgkin's, but can also happen. So these are the independent lymph node regions. These are important when you have to say whether it is stage 1, stage 2. Now, suppose you have one cervical lymph node and a supraclavicular. As you can see, cervical, supraclavicular are the same lymph node region. So it will be taken only as one. So if you have a cervical and an infraclavicular, that will, and there are no other lymph nodes, that will be stage 2. So you have to note the lymph node regions. These are the lymph node regions with respect to staging. So again, I think the risk stratification, the COG Euronet has different, been slightly different risk stratification. And when it comes to risk stratification, not only the stage, but also your connotations are important, whether there is A symptom or not, if the B symptoms or not, sorry. If B symptoms are there, it is, you have to add B. If B symptoms are not there, it will be A. Then there is a definition of E sites also can be added if there is extranodal. Then there is what is known as X. X stands for bulky disease. Again, bulky disease, there are different definitions across Euronet, COG, Lugano. So what is generally taken as with respect to mediastinal mass, the bulkiness is you look at the transverse, the diameter of the mass, the mediastinal mass. If it is more than 33%, more than one third of the transverse diameter of the inner rib cage, that is end to end at the level of the hilum. So this transverse diameter is usually measured at the level of the hilum, and this mediastinal mass diameter is measured. If it's more than 1/3, that is taken as bulky mediastinal involvement. With respect to Euronet, they take volume. So volume is based on a CT. Based on CT, you assess the volume, and more than or equal to 200 ml is bulkiness as per Euronet. So for the peripheral lymph node, again, bulkiness for Euronet is volume based. For other protocols, you are taking the long axis, which is if it is more than 6 centimeter, more than or equal to 6 centimeter is taken as bulky for a peripheral lymph node. So this is what we to take, more than or equal to 6 centimeter bulky, which can be a single lymph node or a conglomerated lymph node. So if the conglomeration is there, the whole conglomerated mass is used for measuring the dimensions. So this is a risk stratification you can see across. This will help you in, this is what we use. So what you have to basically know in risk stratification, staging and risk stratification is, first you do the imaging, you do the clinical examination, take a good history, you do the basic investigations, you have a definitive diagnosis, then you do, wherever PET is available, you do a staging PET-CT to stage, you assign a stage, then you add the connotations A, B, or if there is bulky X, if there is extranodal E. And then what you do is finally you have a staging with connotations, and then you have to assign a risk, whether the patient is low risk, intermediate, or high risk. And this risk stratification, as I have said, there is variation across protocols, a mild variation. So whatever protocol is using, you can assign the risk accordingly and give treatment as per the protocols. I think that would be just, I'll stop here, and I think we'll go through certain case scenarios.
Thank you so much, Dr. Overview. Now, so now we'll have the second Anisha session, which is concentrate our understanding staging and distribution by going through 5 or 6 cases that she will present. Over to you, Dr. Anisha. While she uploads her presentation, I think meanwhile we can take a question. So that there is a question that how commonly do you see Walde's ring involvement in Hodgkin?
Yeah, so Walde's ring involvement, so mostly it is seen. It's not like very common, but yeah, it is relatively seen, especially when you adenoids. You can have involvement of adenoids tonsil, but it's not very common, and so it's in the setting of involvement of other lymph nodes too. It is not very common, but yeah, you do see in Hodgkin's. So isolated Walde's ring involvement is very rare in Hodgkin's, but though we have seen a case or so, but otherwise it can occur, not very common. in association with other lymph nodes.
Thank you. Dr. Anisha, you can start your presentation.
Good evening, everybody. I hope I'm audible.
Yeah, you are.
Yeah.
So the first patient, this is a 14-year-old boy who presented with the swelling in the left side of the neck for 6 months, which was gradually increasing in size. No swellings noted anywhere else, no B symptoms. Investigations for TB were negative, and outside USG showed large conglomerated hypoechoic nodes with loss of fatty hilum with suspicion of lymphoma. The biopsy was suggestive of a classical Hodgkin. On the PET CT, FDG avid nodes were noted in the left cervical region, levels 2, 3, and 4, the largest being 2.2 centimeters. There was no significant intradiaphragmatic adenopathy. The liver, spleen, and marrow appeared uninvolved, and the rest of the scan showed physiological tracer uptake. So what would be the stage and risk? So in this case, as we can see, the left cervical nodes are involved in levels 2, 3, and 4, which is basically one region. And there is no involvement anywhere else. The liver, spleen, and marrow are also uninvolved, and there are no B symptoms. And it is not a bulky disease. So this would be stage 1A. And stage 1A would be low risk disease. Coming to the next patient, this is a 7-year-old boy who presented with pain over the left side of the neck with slowly progressive swelling for 6 months. Again, no B symptoms, and FNSE was suggestive of Hodgkin lymphoma. And he had a left-sided neck mass, which was 6 into 6 centimeters, which clinically is a bulky disease. There was no hepatosplenomegaly. The left cervical lymph node biopsy was consistent with classical Hodgkin lymphoma. And the PET CT was suggestive of a conglomerated left cervical nodal mass, which was 7 into 8 into 6 centimeters, from left cervical level 2 to left upper paratracheal region. And there was significant bilateral cervical lymph nodes, which are in level 2. Also, there is FDG avid nasopharyngeal soft tissue, which measures 0.8 into 1.8 centimeters. The rest of the PET CT was showing physiological uptake. So here, as we can see, there is conglomerated left cervical nodal mass, which is bulky. So this would be stage B. And there are bilateral cervical nodes involved, going up to the paratracheal region also. So there are more than 2 lymph node regions involved. So this would be stage 2AX, as there are no B symptoms. So this would be 2AX. Now coming to the next patient, okay, before we go to that, 2AX would classify as intermediate risk. Normally stage 2A would be low risk, but because this has bulky disease, this would go up to intermediate risk. So as ma'am has already defined, bulky disease would classify as a mediastinal lymph node of more than equal to 33% compared to the transverse diameter of the mediastinum at the level of the hilum, or non-mediastinal adenopathy of more than 6 centimeters, which this child had clinically as well. In comparison, Euronet defines bulky disease as more than equal to 200 ml on CT. Now coming to the third patient, this is a 9-year-old boy with fever for 3 months, which was intermittent, and left cervical nodal swelling of 2 months. There was no other B symptoms. The chest X-ray also showed a mediastinal mass, and the lymph node biopsy was suggestive of classical Hodgkin. The PET CT shows conglomerated right-sided mediastinal mass abutting the lower trachea.
Did she go offline?
Yes, I think so. And I don't think we could see the last few slides either.
Okay, I think I'll share it, then I'll do it. Sorry for that. So I think she did, this was done, right? Yeah. So we'll go to the case 3. So this is a 9-year-old boy with fever since 3 months. There is a left cervical swelling, no weight loss or night sweats. Chest X-ray showed a mediastinal mass. The biopsy was classical Hodgkin's. An FDG PET was done, which showed a conglomerated mediastinal mass, more than 6.6 centimeter, 6.5 into 9 centimeter. Bilateral cervical lymph nodes, mediastinal nodes, Splenic hyla nodes, multiple focal splenic lesions, and liver system, skeletal system appear unremarkable. No, so now with respect to the staging, as we can see, above and below the diaphragm is involved. So it is minimum stage 3. There is no disseminated visceral involvement. So it stays at stage 3. With respect to B symptoms, yeah, fever is there since 3 months, unaccounted for. So that is stage 3B. And if you look at the mediastinal mass, it is 9 centimeters. So yeah, so I mean, it would be more than 1/3 of the mediastinal diameter. So that should be stage 3B. X. So whenever spleen is involved, you can add a connotation of S also. I mean, doesn't make much of a difference with respect to treatment though. But so this is stage 3BX. So anything more than 3A will be high risk. So this is high risk. Now case 4 is a 4-year-old with a left neck swelling for 8 months. There is no weight loss, no sweating. There is fever associated with ear discharge for 3 days. Biopsy, classical Hodgkin's. There is a lymph node palpable. PET CT shows a left cervical lymph node, 3 centimeter, left infraclavicular lymph node, 2 centimeter. Now, what's the stage and risk? Now, let's look at it. So, staging, if you look at it, the PET CT is showing only supradiaphragmatic disease. So, it has to be stage 2 or below. Now, if you look at it, there is left cervical and left infraclavicular. From the picture that I showed you, infraclavicular is a separate lymph node region. So there are 2 separate sites involved, and this is above the diaphragm. So this is stage 2. If you look at the size, there is no bulkiness, so there is no X. But if you look at B symptoms, there is some fever. But again, you have to be careful here. The fever is associated with a ear discharge. So it is unlikely to be associated with the Hodgkin's, where the symptoms have been there for more than 8 months. So we will not take this fever as a B symptoms. So eliciting history is very important in Hodgkin's. So this will come to stage 2A. So it will be stage 2A. So that will be again be low risk. Now, so this I mainly took this case to bring about, to tell you how important is to get a history of B symptoms. So this is low risk because it's 2A. If that fever had not been due to that infection and it had been a B symptom, that would be stage 2B. And automatically stage 2B will be intermediate risk, where you have to give a more intensive chemo. So you have to be careful in delineating this and assessing risk status. Now, case 5 is a 7-year-old child with a fever and weight loss for 8 months, occasional abdominal pain. There is splenomegaly. PET CT shows a para-aortic lymph node, splenic enlargement with focal uptake. No other abnormality detected. So let's see what the stage is. So there is one lymph node involved, which is para-aortic, infradiaphragmatic, and there is spleen also. So there are 2 regions which are involved, infradiaphragmatic. So spleen will be taken as a lymphatic site. Spleen is always a lymphatic site. This is not mere splenomegaly, but there is also focal uptake. So this is involved. So there are 2 lymphatic sites, but both are below the diaphragm. So this will be stage 2. And the B symptoms, history of fever. So stage 2B and no bulkiness. So this will be stage 2B. And this will be intermediate risk. Well, one thing to know is pure merely infradiaphragmatic disease is very rare in Hodgkin's, and it usually accounts for only 3% of the total Hodgkin patients. But you can sometimes encounter such patients. Now, this is a 9-year-old child with a left neck swelling for 4 years. There is an axillary swelling, no weight loss, sweating, but there is fever, Biopsy, lymphoma, lymph nodes are there. PET, when it was done, it showed a cervical lymph node, which is not bulky, an axillary lymph node, which is also not bulky. There is infradiaphragmatic also, adenopathy, and there is multiple splenic lesions. But what is there is, it shows an increased uptake in liver. So there are lesions above and below the diaphragm. So definitely stage 3. Now, as we have said, any patchy uptake in liver marrow will be taken as stage 4. So this is a stage 4 with B symptoms. There is a stage 4B. So this will be high risk. Now this child is a 6-year-old with neck swelling, intermittent fever, treated with homeo, biopsy, Hodgkin. There is a hepatomegaly and a lymph node swelling. PET showed a cervical lymph node. That's a single region, 6 into 3.4. So it is around 6 into 3.4. We'll qualify for bulky. Hypermetabolic, multiple splenic lesions. So spleen is also involved. Now, you can see above and below the diaphragm, there are one each region involved. So it is stage 3 minimum. Now, the child also has hepatomegaly, but there is no increased FTG uptake as per the PET-CT. So this is where you have to see that the liver is not actually involved by lymphoma, but hepatomegaly may be due to some other reason. So this is two regions above and one above and below will be stage 3. Because of fever, it will be B. So this will be stage 3B, and the lymph node was bulky, so it will be X. So this again will be high risk. So that was a few case scenarios just to make you understand how you assess the involvement of the regions, and how will it help you in defining a risk status. And because the strategy again, the treatment strategy again depends upon your risk status. Thank you. That will be it.
Thank you, Badira, and thank you, team TMH, for bringing out those important aspects of staging in Hodgkin's lymphoma. We now move on to management aspects, and if I could welcome, if Dr. Nisha Iyer is logged in. Yes, thank you. So Dr. Nisha Iyer, who's faculty. We can't hear you. You're on mute.
I'll share my content now.
Yes, please. Yeah. So I'll just introduce in the meanwhile. So Dr. Nisha Iyer is a faculty at LTMC and Sion Hospital, Mumbai. Many of us know her. Invite you. Very glad to have you here as expert speaker for management on Hodgkin's lymphoma. Over to you.
Yeah, can you hear me and can you see my screen?
We can hear you, but we can't see your screen yet.
1 second. Yeah, is it now? Can you see my screen?
Yes, we can.
Okay, so I'll be talking about the current approaches for chemotherapy for Hodgkin lymphoma. So basically, as of 1950s, the early 1900s, it was uniformly fatal. And however, some studies in mice models of lymphomas where multiple agents were used, and simultaneously childhood ALL where multi-agent chemotherapy showed prolonged remission, made NCI, the Solid Tumor Service of NCI, explore a pilot of MOMP-based multi-agent chemotherapy in 1963. Because of its success, they were able to, I'm so sorry. They were able to then start the MOP regimen-based chemotherapy for about 43 patients. And they had remission rates as high as 81%. And while there was toxicity, but it was still manageable. Long-term outcomes of about 198 patients treated with MOP showed that the relapse-free survival was about 54%, 55%. However, there was like a 1/3 subsequent malignant neoplasm rate, which was quite high. So looking at other options, they found that drugs which were non-cross resistant or minimally cross resistant with the MOP regimen like ABVD also was quite effective, and their outcomes with respect to disease-free survival as well as prevention of second malignant neoplasms was much lesser as compared to MOP. So basically, coming from the 1970s, we have outcomes as good as 90%. So going forward, the only way forward now is to reduce the toxicity caused by the existing chemotherapeutic regimens. So risk-adapted therapy is what we are moving towards. It's mainly from the point of view that not all diseases or not all Hodgkins will behave the same way. So while the initial stage might determine the initial intensity, the rapidity of response may help determine the choice of consolidation therapy and even potentially completely avoid radiation therapy. Again, even gender may help determine the choice of agents for chemo as well as in radiation. The aim basically is to give the most effective chemotherapy, therapy with the least acute as well as chronic toxicity. So that's what we move towards. A quick note on the histology-based therapy. Now, nodular lymphocyte predominant Hodgkin lymphoma is a variant that generally presents with a favorable risk. It responds well. In fact, stage 1 single nodal involvement, you can get away with just surgical resection without any chemoradiation with great outcomes. If you see on the extreme right, survival is uniformly 100% for patients of nodular lymphocyte predominant Hodgkin lymphoma. It's a little rare to find advanced stage disease, but when you do, we don't really have large protocols, large groups of patients presenting like this. You would likely treat as the same protocols as classical Hodgkin, but they are more likely to do better with respect to outcomes. Classical Hodgkin, while nodular sclerosing is supposed to respond less better than mixed cellularity, they are still uniformly treated with uniform protocols. Now, the protocols used for the treatment of low-risk Hodgkin, there are multiple. It will be impossible to talk about all of them. I'll just talk about a few. Initially, the ABVD or the DBVE protocol. Here, about the P9426 evaluated about 255 children. They gave DBVE 2 courses. Rapid early responders, those in CR received radiation. And those not in partial remission or stable disease received 2 more chemotherapy, 2 more cycles of DBVE followed by radiation. They also randomized patients to receive or not receive dexrazoxane. They mainly wanted to see response of the response-dependent therapy algorithm if it works, and to study if dexrazoxane reduce the long-term cardiopulmonary toxicity. So their outcomes are great. OS of 97%, EFS of 86%. EFS did not seem to be affected by the rapidity of response, mainly because you're able to consolidate your therapy well, and the number of cycles received. The lymphocyte predominant histology had a trend towards better OS and EFS. Stage 3 patients, they included stage 3 in this. They are low risk, included stage 3A. So they had a slightly lower EFS and equal OS. So they were able to salvage their relapsed patients. So the dexrazoxane toxicity with respect to the dexrazoxane arm, it was found that there was a higher hematological toxicity in the dexrazoxane arm, as well as a slightly higher incidence of SMNs in the dexrazoxane arm, probably because etoposide, doxo, as well as dexrazoxane is being given. However, long-term protective action on the cardiopulmonary toxicity it'll take some more time for that paper to come. Now, this I feel paper. This is, I feel, is an interesting paper, the AHOD 0431. Now, what they've tried to do is they are trying to overall survival.
Sorry, Dr. Nisha, just a moment. Can I request everyone to please mute their mics so that we can continue with the presentation? Thank you.
Okay.
Sorry, please go.
Yeah. So, what, like I was saying, AHOD 0431. The aim is to optimize the OS rather than the EFS. Why? Because they feel there would be a certain segment of the low risk patients who would get away with minimal chemotherapy and no radiation. And even if the ones who relapse, who do not, because of the compromise in EFS, the ones who relapse can be treated with a slightly more intense chemoradiation therapy without need for auto transplant. So they gave about 175 children were given about one cycle of AVPC, and a PET one was done immediately after after the first cycle of AVPC. Those in CR received 2 more cycles of AVPC. The second PET also confirmed the CR, no further treatment. If they were not in CR after PET 1, they received 2 cycles of AVPC followed by radiation. The salvage chemotherapy for a protocol-defined low-risk relapse was VI for 2 cycles, followed by DECA for 2 cycles, and then radiation. So their outcomes are actually, EFS is about 80%, OS is they managed to salvage almost all their patients. The EFS without RT was about 50%. So 50% of their patients got away without radiation. The ITFS, that is intensive therapy free survival, is close to 90%. So they were able to get away with high dose chemo followed by stem cell rescue in almost about 90% of patients. they found that the presence of the nodular sclerosis type histopathology, positive PET1 and a high ESR was the group of patients who tended to relapse. So maybe on a larger scale, if you give just one cycle chemo and check for a response, and if you don't have other high risk features, you probably could get away with a very small amount of chemo and or radiation. GPOH 2002 took about 195 low risk children, and they just gave 2 OIPAs. CR, if there's CR, no RT. If there was no CR, they gave RT. Their outcomes for 5-year EFS was about 92%, and OS, irrespective of radiation, was 100%. They were able to omit RT in about 32% of their treatment group 1, which is the low risk group. This is a Canadian paper. This includes children as well as young adults with all stages. I'm going to only pick out the low risk group among this. ABVD, 2 cycles, response assessment, rapid early response. They gave 2 more cycles of ABVD and no RT. Slow response, 4 cycles of ABVD. All adolescents received RT. The children received RT only if the end of treatment imaging showed disease, a likelihood of disease. So their outcomes are about 98% OS and 90% progression-free survival. They had to give 10% of pediatric cohort required RT, what risk they belong to. So this is, as I mentioned, it involves all risk Hodgkin. I've only taken out the low risk outcomes, but 10% belong to what risk is, I'm not sure, it's not clear in the paper. Coming to intermediate risk Hodgkin. Intermediate risk Hodgkin has a bunch of protocols. We will go through a few of them. So first being the Euronet PHLC1. They had about 435 patients belonging to the treatment group 2. Their aim was to show non-inferiority of COPDAC to COP and to prove reduced gonadal toxicity of the COPDAC-based regimen. 2 OIPAs, early response, they gave 2 COPDACs and no further chemo. Inadequate response, 2 COPDACs followed by radiation. Their outcomes with respect to PFS and OS of the adequate as well as the inadequate response group was similar. Their outcomes with respect to EFS and OS of the entire COP versus COPDAC group was also similar. Now the catch. So while the EFS of the COP versus COPDAC in irradiated patients with inadequate response was similar, they found that when COPDAC was given in adequate response patients without radiation, their outcomes were only 83% as compared to only COP without radiation, where outcomes were as close as 92%. So basically, treatment group 2 with good early response, only 2 cycles of COPDAC without RT is inferior to 2 cycles of COP without RT. Now, the Senju group, they took the same backbone, and in a prospective trial of about 27 children, I'm sorry, of intermediate risk, for after 2 OIPAs, if they got a good adequate interim response, they gave 4 COPDACs and no RT. And inadequate response they gave 4 COPDACs followed by RT. Outcomes, 3-year PFS is about 100%. And the 3-year PFS of their historical control, which received Stanford 5 and ABVD, was about 83%. Outcomes OS, so survival probability is not very different, but the PFS was significantly different when 4 COPDACs were given. Then we have the P9425. They gave a risk-adapted response-based approach using ABVEPC. Their backbone was ABVEPC. 216 patients with intermediate and high-risk Hodgkin. They received dose-dense regimen that every 3 weeks they were given ABVEPC. 3 fractions of ABVEPC was followed by an imaging. The rapid early responders were given radiation. The slow responders were given 2 further cycles and 21 gray radiation. Their 5-year EFS was about 84% for the intermediate group. We'll talk about the high risk group when we come to high risk. EFS for the 3 versus 5 cycles was similar. EFS for the rapid versus slow responders were also similar. 5-year OS was 95%. So basically, consolidation is has worked. Then there is AHOD 0031, where they gave 2 cycles of ABV EPC. So this sort of followed the previous cycle of 9425. Where instead of rapid response assessment, the response assessment being done at 3 cycles, they did it at 2 cycles. And when they got a rapid early response, they gave 2 more cycles of ABV EPC, followed by randomization to receive or not receive radiation. And the slow early responders, they've tried to consolidate their therapy by augmenting the chemotherapy by giving DECA and ABV EPC for 2 cycles each, followed by radiation, and compared it with only giving ABV PC2 and radiation. So outcomes for the whole group was about EFS of 85%, OS of 97%. The rapid early responders and slow early responders, similar EFS and outcomes. That wasn't really different. Giving IFRT versus not giving IFRT did not make much of a difference too. So we could get away without IFRT for the rapid responders. The catch, they found that in the slow early responders, when the subsequent PET was still positive, the EFS was slightly higher with a chemotherapy augmentation in the chemotherapy augmentation arm, borderline statistical significance. So they basically determined a population of early responding CR, intermediate risk Hodgkin, in whom IFRT could be safely avoided without compromising outcomes. GPOH 2002. They studied the OPA versus OIPA. They did not give procarbazine for boys because of the gonadal toxicity. They have given COP for consolidation in girls and COP-DAC for the boys. Again, because of the increased sensitivity of boys with respect to gonadal toxicity. And their outcomes for the treatment group 2 is an EFS of about 88.3%, and they found that OIPA COP-DAC is not inferior to OPA COP. But remember, this has been radiation has been given to all the patients. High-risk lymphomas, these are the protocols that have been used. We'll talk about a few of them. Our own Indian data of INPOG, 262 children with advanced Hodgkin, stage 2B, 3, and 4. 2 cycles of ABVD were given, and interim response assessment showing good response received 6 further cycles of ABVD, and inadequate response received 6 cycles of ABVD, followed by an IFRT of 21 gray. We have great results of 90% OS and an EFS of 81%. However, it was found that giving radiation improved the EFS to almost 90% as compared to 75% for the group that did not receive radiation. So when giving, so sort of like the backbone of ABVD would require, for advanced stage Hodgkin lymphoma, would require radiation to help consolidate the response. GPOH 2002, again, now this is for GPOH for TG3, the treatment group 3. So about 239 children received, we know the protocol that they received. Again, treatment group 3 had a EFS of 86.9%. So up until now, this is sort of one of the best EFS for this treatment group 3. And again, non-inferiority, we've gone through these graphs. Euronet PHL had 852 patients belonging to treatment group 3. Adequate 2 cycles of OIPA was followed by response assessment. Adequate responders received 4 cycles of COP-DAC, no RT. Inadequate responders received 4 cycles of COP-DAC followed by RT. Their outcomes, 5 years for the entire subgroup is about 86.6%. For the adequate responding group is again 86-87%, and for the inadequate responding group is also similar. BCOP-based chemo. BCOP is another one of the more intense chemotherapies used for patients with advanced stage Hodgkin lymphoma. 4 cycles of BCOP followed by response assessment. Where there was good rapid early response, the females received COP ABV 4 cycles. The males, because of the gonadotoxicity, received 2 cycles of ABVD followed by radiation. The slow early responders received 4 more cycles of BCOP. So they have one of the one of the best outcomes for treatment group 3 or advanced high-risk Hodgkin lymphoma, with an EFS of 94% and an OS of 97%. If you compare it to the various other POG, GPOH groups, this outcome is actually one of the best. There is a lot of toxicity with the BCOP regimen. The toxicity increases with progressively increasing cycles of BCOP. You can almost like 96% of the BCOP receiving patients develop neutropenia. Febrile neutropenia is to the range of 25%, but this is in the Western context. Our rates would definitely be higher. Mucositis, pharyngitis, stomatitis was significantly higher. Long-term toxicity, gonadotoxicity would also be higher. Now, what another St. Jude group did for HLH-R13 is they replaced with the OIPA-COPDAC backbone. Instead of vincristine, they replaced the vincristine by brentuximab vedotin. And they wanted to see the efficacy of this with respect to OS and EFS compared to the historical trial, and also assess the safety of brentuximab vedotin. They gave similar to the GPOH 2002 backbone. They gave residual node radiation therapy rather than IFRT. So they were able to omit radiation in 35% of their patients with high-risk disease. There were no relapses in the non-irradiated cohort. In the irradiated cohort, they had one local relapse in the initial involved site. However, that site was not covered by the radiation because the radiation was to the residual node. The safety was comparable to OIPA-COPDAC. There was, however, one sudden cardiac death, which which needs to be evaluated when this protocol is used on a larger scale. And neuropathy was much lesser as compared to adults, just 4% of grade 3 neuropathy as compared to 11% in adults. Outcomes are to the range of 97% EFS and OS of 98.7%. So this is one of the best outcomes for a high-risk group. This is very interesting if this can come out in a large-scale study. Now, one of the other things I had to talk about was OIPA-COPDAC versus ABVD. For low risk, it looks to be similar. Outcomes for EFS and OS for OIPA and ABVD seem to be almost similar, 98 and 100%, 90 and 92%, just a 2% difference. Comparing for intermediate and high risk. So EFS for the ABVD cohort was 81%, as we just saw our INPOG outcome, and OS was 90% as compared to an 88% outcome in OIPA-COPDAC and 99% in OS in OIPA-COPDAC. Also, in the if you take the treatment group 3 population in the INPOG cohort, their outcomes were only 77% as compared to 86.6% in the Euronet PHL outcome. So look, advancing disease, poorer the outcomes with ABVD. ABVD might not be enough for, is not enough for advanced stage Hodgkin lymphoma. Coming to acute toxicity, where best to see toxicity except India. So PGI have started giving OIPA-COPDAC, and they found the incidence of febrile neutropenia as 32%, and most of it, two-thirds of it, was after the first OIPA. Most of their deaths followed the first OIPA. COPDAC, they did not have any mortality after COPDAC. Their treatment-related mortality was 5.3%, which is actually very high for a Hodgkin lymphoma. While GPOH did the same chemo, their grade 3, grade 4 infections were rare, but again, we cannot compare our infection rates with them. Toxicity, if you see the toxicity part of this table, so there's a Pakistan group which has a treatment-related mortality of 7.5%. The PGI group had about 5.3%, as compared to the toxicity of ABVD-based chemotherapy, where toxicity is very minimal. 0.6, 0.2, nil, treatment-related mortality is minimal. So toxicity is higher with the OIPA-COPDAC regimen as compared to ABVD. So short-term supportive care requirement for OIPA-COPDAC is definitely more. EFS and OS is still higher in the OIPA-COPDAC arm, especially for advanced stage Hodgkin. So I feel that rather than compromising the disease-free survival, we should aim at improving our supportive care follow-ups and counseling to make our chemotherapy, to be able to give more effective chemotherapy. Long-term toxicity with ABVD is, theoretically known to be more. So there's a lot of papers on a cohort followed for 5 to 10 years, and in them it was found that there were no symptomatic toxicities, outcomes weren't too bad. However, to know the impact of ABVD and toxicity, the cohort needs to be followed for a period of 40-50 years rather than just 10 years, 30-40 years rather than just 10 years. And it's difficult to find pure studies where only ABVD was given and then for long-term follow-up was done for 30-40 years, because radiation, how much of the long-term toxicity is impacted by radiation, how much of the long-term toxicity is impacted by MOP and other chemotherapy is difficult to say. However, theoretically, increasing doses of anthracycline, bleomycin, and RT leads to adverse cardiac, pulmonary, and thyroid complications. So cumulative doses for ABVD in advanced stage Hodgkin, where you have to give 6 cycles, is about 300 mg per meter square. Doses above this in children cause 10%. 10% of children receiving this would eventually experience anthracycline-induced clinical heart failure. Bleomycin also, again, it's a little idiosyncratic. Then cumulative. Now, this is a St. Jude lifetime cohort study where about 630 Hodgkin lymphoma survivors were compared to 270 community participants matched for age and sex. While this is not a pure data, it is about patients with Hodgkin who have received various chemotherapy. If you see the graph on the right, the diagram on the right, the survivors do at 30 years do have an increased cardiac toxicity, this is much more at 50 years. The toxicity is mainly left ventricular dysfunction, dysrhythmias is what is more common. But again, like I said, I cannot really separate out only those receiving ABVD. Long-term toxicity of OIPA-COPDAC, now at least with respect to the cumulative doses, etoposide has not reached its cumulative dose of beyond 2 gram per meter square that increases the risk of SMNs. Cyclophosphamide, you reach the 4 gram per meter square when you give 2 OIPA and 4 COPDACs. And it's just 2 decades of OIPA-COPDAC, so I think it will take a little longer to see long-term toxicity. Dacarbazine has been proven in the GPOH 2002 as well as the Euronet PHL to be less gonatotoxic than procarbazine. So with respect to ABVD in the treatment of Hodgkin lymphoma, the American College of Radiology appropriateness criteria, they believe that for all treatment groups with varying cycles of ABVD and radiation, ABVD-based chemotherapy was considered usually not appropriate or just may be appropriate. So the results of the winner is OIPA-COPDAC in the ABVD versus OIPA-COPDAC debate. Now, in Indian scenario, we have a paper from the older PGI cohort have outcomes of OS of 92.7% and EFS of about 78%. They've given various chemotherapy protocols like ABVD-COP, MOP-COP. They've only, in the 207 patients, they've only radiated 3, but the outcomes are not bad. Then we have the PGI's OIPA-COPDAC based chemo where EFS is about 86% and OS is about 93%. While we've already discussed the treatment-related mortality was 5.3%, the outcome, the EFS and OS was still better. And the PGI group found that when your chemo backbone is OIPA-COPDAC, on multivariate analysis, B symptoms, bulky disease, gender, malnutrition, lost impact on survival and relapse. TMH for low risk gives ABVD with or without RT. OIPA for intermediate and high risk gives OIPA for intermediate, 2 OIPA, 2 COPDACs with or without RT, and again 2 OIPAs and 4 COPDACs without RT. They have excellent outcomes. Low risk is about 100% EFS-OS. 3-year for intermediate risk has a 94-95% EFS-OS, and even the high risk groups has 90-92% EFS and OS. Chennai Adyar has given ABV-COP based regimens. Their concept is to more than absolute numbers like 4 or 6 cycles of chemo. They have given 2 cycles more after achieving radiological CR. So their outcomes for low risk is quite good. EFS is 96 and 91%, 92%. So for the stage 4 though is a little suboptimal, 70 and 57%. ICMR has given a set of chemotherapeutic regimens for various risk Hodgkin lymphoma, because the reason for giving ABVD based chemo for favorable, intermediate as well as advanced stage is given by ICMR is mainly, I believe, because they did a consensus and about 75% of the pediatric hemato-oncologists in India are used to, and they give ABVD based chemotherapy. And follow-ups, ease of giving the chemo is definitely easier with ABVD based chemotherapy. So, treating and salvaging those who can be is the priority here, which is why ABVD has been included in their various protocol, in their various recommendations. Now coming to RT, it was actually RT in Hodgkin lymphoma that first published a paper that Hodgkin lymphoma can be cured. And this was in 1963, in the June of 1963, where about of 800 patients with localized Hodgkin, 226 survived for 10 years with only RT, and 191 were able to survive for 15 years. So basically RT is an important part of Hodgkin, and Hodgkin is a radiosensitive disease. So with improvement in systemic therapy, the dose and requirement of RT is most certainly reducing, and sophisticated target definition helps reduce the field of radiation and the impact on the surrounding normal tissue. Now, if we look at the image on the right, so the center is the PET and the involved nodes are delineated by the pink contours. If I say radiation, the mantle radiation would for this mediastinal node would include the neck, the axilla, and the mediastinal node that is involved. IFRT is similar to ISRT, only it was developed at the time before 3D CT, before CT was used for planning of RT. And therefore it uses two-dimensional imaging techniques like X-ray for planning the RT. So IFRT will still include neck and upper, a larger volume than what was shown than the 3D CT or a CT based planning, which is ISRT. As you can see, ISRT uses lesser, the lesser field surrounding tissue damage is lesser with ISRT, and with residual disease RT, residual node RT, you only post chemo, whatever residual disease is left in the node, only that is irradiated. Intensity modulated radiotherapy basically helps greater sparing of the organs at risk adjacent to the target volume from receiving higher doses at the expense of increasing the normal tissues receiving a low to intermediate dose. Doses generally range from 12 to 25 gray with boosts up to 30 to 36 gray. So terminologies, there is the pre-chemotherapy gross tumor volume, there is the post-chemotherapy gross tumor volume. So the clinical target volume is taking into account the reduction in the transverse diameter that has occurred with chemotherapy. Internal target volume is the clinical target volume plus the margin to account for variation in shape and motions in the patient. And the planning volume is the ITV or the ITV plus the variation in the daily setup of the radiation. Organs at risk, we've just, so radiation terminology. Basically coming to this slide, when we are doing the initial staging, when we are doing a PET based staging helps, should be done in the position in which the radiation would ultimately be given. So generally for cervical Hodgkin, one would want to do a PET in the neutral, neck neutral or extended position. In this case, planning for the eventual RT becomes easier. Similarly, planning RT with PET not just PET with contrast enhanced CT would help reduce damage to the surrounding tissues as well as optimize radiation to the target required, and thereby help optimizing its efficacy while reducing its toxicity. Ongoing trials, there are a lot. I've just picked two. Euronet PHL2C2 is trying to look at intensifying their chemotherapy in the where residual disease is left by giving the Copdac rather than just Copdac, and giving it over 21 days rather than 28 days. Immunotherapy is, I think, the next thing that will change Hodgkin, and so soon Hodgkin will be a disease with outcomes of nearly 100% for all stages. So that's it.
Thank you, Dr. Nisha, for that excellent overview on very systematic overview on the stage-wise treatment of Hodgkin lymphoma, and also bringing out the experience of various centers within India and outside, and giving us a viewpoint on what would be most appropriate for each of us to use. House is actually now open for questions and comments. There's a couple of, there's one question in the chat box that I'll ask you. In involved field radiation therapy, the involved nodes in staging PET are irradiated, or only the involved nodes in reassessment PET? I think you perhaps answered this question, but if you could clarify again, please.
So it's based on the initial PET rather than the post chemo.
Yeah, so all therapy is based on how it was at presentation, the involvement at presentation. So House is actually now open for a couple of questions. We have 5 minutes probably for any questions from many seniors and experts are here in the forum today. Any comments, questions from anyone? House is open.
So I have a question. So sometimes we wondered, like, this concept of interim PET, it is very much well applicable when we use Euronet strategy. But when we use ABVD in LMICs, how much is the data robust to suggest that yes, we can follow a interim PET guided radiation in the context of ABVD?
So you want to know if the interim PET can help guide radiation, whether interim PET helps guide radiation for ABVD based chemotherapy?
Yeah, precisely.
Yes, it does. If the interim PET does show a CR, you can potentially obviate the need for an RT, especially in the low risk groups, and with respect to intermediate and high risk groups, based on your, maybe if you have a bulky disease, you would still want to irradiate, but without other risk factors, I would personally feel that advanced disease Hodgkin, if they're giving an ABVD based chemotherapy, it's better to irradiate. Especially if you have a interim PET that is showing disease.
Yeah, Pritam, if I may.
Yes, ma'am.
Hello.
Please.
Yes, please, Badira.
So you are asking the significance of an interim PET in ABVD based chemotherapy for a RT decision?
Yeah, what I'm trying to mean is this interim PET has been basically most of the time from the Euronet strategy. So we are basically extrapolating the same concept to the ABVD treated people also.
Okay, so
is that extrapolation all right?
Yeah, no. So if you have to see, if you're giving an ABVD based chemotherapy, you have to understand that ABVD is not that a very intensive chemotherapy as an OIPA Copdac, which is what is used in Euronet. So apart from a low risk disease, the use of an interim PET to guide your RT decision this is not the way to go in an ABVD based chemotherapy. So in an advanced stage disease, irrespective of the interim response, have to be consolidated with RT. If you're giving an ABVD based chemotherapy, this was shown in an RCT which was done by Dr. Laskar and all, where in JCO which was published, which showed that advanced disease needs consolidation RT irrespective of the response if you are giving an ABVD based chemotherapy. If you're looking at an RT elimination, then your backbone chemotherapy should be intensive. That is where you can use any OIPA, COPDAP, ABV, PC, whatever be. But having said that, in a low risk disease, you can give ABVD, and there even though it is not quite common, you can get an interim PET showing a residual disease, which has to be consolidated with RT after 2 cycles of ABVD. If you have good response, there is no need for consolidation.
Yeah, the INPOG also, if you see the INPOG outcomes, EFS is actually better in the group that received RT than not. And INPOG group actually gave ABBD based chemo. So, yeah.
Thank you. Any other questions or comments? So whilst people are thinking, the next session on March 9th, so second Thursday in March, is going to be on relapsed ALL. We have the team from SRMC Chennai to present the approach and risk stratification, and Dr. Shekhar Krishnan from TMC Kolkata to talk about the treatments, where we are in 2023, and also share some of his experience from the TMC ALLR1 study. So if there are no further comments, questions, I think we can bring the session to a close. So
there is one quick last question.
Oh, there is. Oh, sorry. Yes, I just saw that. Sorry. So Ajita, thank you for the question. If I could put it to the two experts, ABVD based chemo with advanced disease needs RT only in bulky or interim PET positive region and not all. Is that correct? Like stage 4B non-bulky with RER require only 6 ABVD and no RT is what she's asking.
So yeah, again, see, like Badira also said, and Laskar sir and the INPOG data, it's maybe I would err on the side of giving RT in a backbone of ABVD based chemotherapy for an advanced stage Hodgkin. Because the efficacy, event-free survivals are better when RT is given as compared to when RT is not given. So.
Okay, right. Thank you. So I think we bring this session to a close. Thank you, everybody. Thank you to the team from Mumbai for excellent show today. So thank you, and thank you, Preetham, and thank you, Echo, for providing us this platform to continue this educational forum, which is really very popular. And thank you to all the trainees for joining in, for participating in the discussion. Good night, everybody.
Thank you.
Bye.